Good morning, and thank you for joining us this morning for Winship Grand Rounds. If you're an Emory University or healthcare employee and would like to receive CME credit hour for attending today, the login information can be found in the chat feature on the bottom of your screen. If you have any issues with this webinar or the CME login, please send Julie Hawkins an email or drop a note via the chat feature. So this morning, we are pleased to welcome Dr. Rachna Shroff. Dr. Shroff comes to us from the University of Arizona College of Medicine, Tucson, where she joined in April of 2018 as an associate professor in the Department of Medicine, Division of Hematology and Oncology. She's currently chief of the section of GI Medical Oncology at the UA Cancer Center. Prior to joining at Arizona, she completed her fellowship in medical oncology at University of Texas MD Anderson, where she simultaneously obtained a master's degree in the Graduate School of Biomedical Sciences. She later did her residency in internal medicine at WashU in St. Louis, and she also served as a chief resident at the VA hospital there. She earned her medical degree from Jefferson Medical College in Philadelphia and a bachelor's degree in biochemistry, and graduated with honors from Brown University. She has been very active at the national level, and really an expert in GI oncology, in particular biliary cancers that she'll be talking about today. She's been a member of the ASCO Scientific Committee in the non-colorectal tract, as well as the ASCO GI Guidelines Advisory Group. She participates in the SWOG GI Committee and the NCI Hepatobiliary Task Force. And where I met Dr. Shroff was in regard to the Cholangiocarcinoma Research Foundation. She's very involved in these networks and participates in the Novel Targets Working Group for the International Cholangiocarcinoma Research Network. So at the institutional level, she is the leader of the GI Oncology Disease-Oriented Team at University of Arizona's Cancer Center, and she also serves as the Associate Dean of Clinical and Translational Research for the College of Medicine. She has extensive amounts of leadership roles. She's very busy, so we're thankful for her time today. She's medical director of both the CTO as well as the Arizona Clinical Trials Network, and she has previously been chair of the University of Arizona Cancer Center Data Safety and Monitoring Board. So Dr. Shroff has a really impressive vision for the section of GI medical oncology and national implementation of therapeutic trials for biliary cancers. And her goal is to provide cutting-edge multidisciplinary care while developing a clinical trial portfolio that offers novel therapeutic options for patients with all sorts of GI malignancies. So we're very honored to have Dr. Shroff today and really looking forward to your talk. Thank you for joining us.
Thank you so much, Dr. Lazinski, and thank you all for joining us this morning, and thank you for the invitation to present to you all. As he mentioned, I am very passionate about biliary cancers, and that is going to be the subject of my talk today. And I hope, I joke that about even 5 to 7 years ago, it would have been hard to give an hour-long talk on biliary cancers. And as you can see today, I think that there is so much momentum and just rapid drug development going on in this space. And I think it's just a really exciting time to be involved in biliary cancers. So these are my disclosures. Biliary cancers, I'm sure I do not need to tell everyone, is a really catch-all phrase that I think is probably somewhat misleading in the fact that all biliary tract cancers are not created equal. It is a heterogeneous group of malignancies that includes cholangiocarcinoma, both intrahepatic and extrahepatic, as well as gallbladder cancer. And biliary tract cancers, as you can see, are not only distinct anatomically, but are also quite distinct in terms of risk factors, types of presentations, and kind of morbidities associated with the disease. We also kind of historically were taught that extrahepatic cholangiocarcinoma was the biliary tract cancer usually of highest incidence, at least in this country and globally. And what you can see here, I think, is that we are starting to see a shifting epidemiology in terms of a steady state increase in incidence of intrahepatic cholangiocarcinoma in terms of relative to extrahepatic cholangiocarcinoma. And I think a lot of that has to do with just increasing obesity, non-alcoholic fatty liver disease, NASH, et cetera. So I'm going to take us through advanced disease primarily. We could talk for an hour as well about resection and localized disease and approaches in that space. But I think in terms of drug development, the focus has really been in the advanced disease setting. And I always like to kind of put everybody into the context of what we've been doing for the last 10 plus years. And I have a 12-year-old daughter who taught me about some meme that I think is very popular with the teens right now about how it started and how it's going. So this is how it started. This is ABCO2. This is the gemcitabine and cisplatin, the pivotal trial that led to gemcitabine and cisplatin becoming standard of care. And this is from 2010, and this is really where we're at in terms of treating frontline biliary tract cancers. But as you can see, it's a much more exciting and somewhat complicated space now in the setting of advanced disease, with gemcitabine and cisplatin obviously still playing a very important role, but with other chemotherapy combination options, targeted therapies in a lot of different areas, immunotherapy, as well as liver-directed treatments and local treatments that are important. And so in my opinion, I think biliary cancers is a perfect example of how we can utilize precision oncology because it's really the poster child for drug development in that space. This is the ABCO2 study. I'm not going to belabor it, but this was a randomized phase 3 trial done in the UK comparing gemcitabine alone to gemcitabine and cisplatin. It was just over 400 patients. And as you can see, the median overall survival is still, while significantly improved, it still leaves a lot to be desired. Median OS was 11.7 months with the addition of cisplatin to gemcitabine. The ABCO6 study became the pivotal second-line study in the biliary tract cancer space. Leading up to this study, there was really no established standard of care after GemCis. And this study looked at FOLFOX with active symptom control compared to active symptom control alone in patients who had progressed on frontline gemcitabine and cisplatin. And here the overall survival endpoint was the one of interest again. The primary endpoint was technically met. The hazard ratio was 0.6 with an improvement in median OS from 5.3 months to 6.2 months. So numerically, really not that exciting of an improvement in median OS. You do start to see a separation of the curves further out at both the 6-month and 12-month survival rates, as you can see here. And you'll note that this is kind of a common theme, I think, in biliary cancers, where there's a pretty quick drop off in the OS curves and then a slight separation. The progression-free survival, though, was only 4 months, still a lot left to be desired. And again, response rate, pretty low, single digits, 5% response with FOLFOX, disease control rate in about a third of patients. So when we talk about precision medicine, I think it's really important to remind everybody that precision medicine is a really important space, of course, and has been a great area of focus in terms of developing therapies for these patients. But precision medicine, unfortunately, is not relevant for every single patient that we see with biliary tract cancers. And why is that? Well, number one reason, I think on average, about 30, maybe sometimes always up to even 40% of patients do not have adequate tissue for comprehensive biomarker testing or next generation sequencing as we tend to use. Extrahepatic cholangiocarcinomas, for instance, are often utilizing biliary brushings and ERCP guided attempts at obtaining tissue. Sometimes that includes an FNA, for instance. And so cytology-based diagnoses, et cetera, often do not provide enough tissue for comprehensive testing. And then oftentimes, even with intrahepatic cholangiocarcinomas, when we do core needle biopsies of a large lesion in the liver, we get a fair amount of necrotic tissue and we get the quantity not sufficient report when we send it off for NGS. Additionally, while we say about 40% of biliary tract cancer patients have targetable alterations, I sit and emphasize to everybody that means that about 60% do not have targets that we can have identified or that are relevant yet, at least, for targeted treatments. And so for that 60% of patients, we need to continue to have novel, all-comer, probably cytotoxic-based strategies to ensure that we have drugs for all of our patients. So to that end, there are a fair number of studies that are looking at novel approaches in the setting of chemotherapy. Nuke 1031 is a protected gemcitabine. When I describe it to my patients, I call it a souped up version of gemcitabine. This is the concept of a proteid transformation of gemcitabine, which in theory overcomes resistance mechanisms. So it's a nucleoside analog that basically helps overcome things like issues related to HENT1 related cellular uptake of gemcitabine, the activation of deoxycytidine kinase, which leads to elimination of gemcitabine, and protection from breakdown by cytidine deaminase. So in the initial study, which was the ABC08 study, which was a phase 1B looking at Nuke 1031 with cisplatin, there was really kind of intriguing efficacy data. And that's what led to the Nuke 21 study. This is an ongoing study right now, randomized phase 3 in advanced biliary tract cancers, all comers. Patients are randomized to Nuke 1031 with cisplatin versus the standard of care, GemCis. Here you will see there are dual primary objectives of overall survival and overall response rate with a hazard ratio target of 0.76. This is a very large study. A little over 800 patients are planned to be enrolled. And so this study is ongoing, but I'm not sure exactly when we're going to see the readout. The Amoebica study was another study of great interest. This was the study comparing FOLFIRINOX to gemcitabine and cisplatin, and it was done by the Prodige group, the group that did FOLFIRINOX in pancreas cancer. And so we were all, this was in the hands of people who know how to give FOLFIRINOX. And I'll be frank, I was expecting this to be a positive study. This was a randomized phase 2 study that was subsequently going to roll into a phase 3 study. Patients were randomized 1-to-1 to receiving GemCis versus FOLFIRINOX. And in the phase 2 arm portion of the study, the primary endpoint was PFS rate at 6 months. And as you can see, GemCis PFS rate at 6 months was 59% versus 51.1% in FOLFIRINOX. So in the intention to treat analysis, this did not meet its primary endpoint. Because of this, the study was stopped and did not roll into the phase 3, and it was felt that GemCis should remain standard of care. I think there are a lot of other areas that people are anxiously awaiting in terms of systemic therapy. One study is SWOG 1815, which is based on a phase 2 study looking at GemCis nab-paclitaxel that was a single-arm study. This was a 60-patient study that enrolled all newly diagnosed biliary tract cancer patients, cholangiocarcinoma and gallbladder. It was done at MD Anderson Cancer Center in Mayo, Arizona, and involved the triplet, GemCis plus nab-paclitaxel. Initially, kind of traditional dosing was used, but after 30 patients, it was felt that there was a fair amount of myelosuppression, and so there were some dose adjustments made, and a subsequent 30 patients were enrolled at a slightly lower dose. And here, the primary endpoint was progression-free survival. You will see here that the patient population was primarily intrahepatic cholangiocarcinomas, 63%, and primarily metastatic, 78% of patients were metastatic at the time of diagnosis. And here are the primary endpoints of progression-free survival and secondary endpoint of overall survival in the intention to treat analysis. As you can see, the median PFS was 11.8 months. Just for comparison of historical control, which obviously is not the right thing to do, but to put this in context, PFS of GemCis is 8 months. Median OS in this study was 19.2 months, and that's really what caught everyone's attention. GemCis, again, 11.7 months. The overall response rate was 45%. The response rates with GemCis is around 25-26%. And then a kind of surprising finding that we found basically by accident is that 12 of 60 patients, or 20% of patients, were actually converted from unresectable to resectable disease and were able to be taken to the OR for a curative resection. 2 of the 12 at the time of publication had a pathologic complete response, but 3 of the 12 ended up having a path CR. This is the waterfall plot that shows most people derived some benefit from GAP, as we call it. And that's what led to SWOG 1815. And SWOG 1815 is the first randomized phase 3 trial for biliary tract cancers in the United States. So it's a really important study just to prove that we can do it, that it's not just the ABC group that can do randomized phase 3s in biliary cancers. This was frontline all comers, again, cholangio and gallbladder. Patients are randomized 2-to-1 to the triplet, GemCis nab-paclitaxel versus standard of care GemCis, with a primary endpoint of overall survival. The initial N was planned to be 268 patients, but that was increased to 441 patients, primarily because of rapid accrual. Now, during the time in which this study was open, Gemcis nab-paclitaxel was added to the NCCN guidelines as well. So a fair number of patients are starting to use this triplet regimen, those who are able to, even outside of SWOG 1815. But SWOG 1815 was closed to accrual in February of this year, February 15th. And I think I use SWOG 1815 as an example of why we can and should be doing studies through NCI mechanisms, the NCTN, ATCTN, et cetera. The honest truth was there was a fair amount of concern that SWOG 1815 would not be able to be done in a timely fashion, both timely from the NCI's perspective of accrual, but also just timely in the sense that we knew that this was a very crowded space. A lot of people were looking at changing the front line. And so I put this slide up just to really remind people that you can actually do something quickly through the NCTN, and this is not an outdated mechanism for clinical trials. As you can see, there was a pretty rapid movement from kind of approving of the concept to getting things up and running and have a protocol written. And in fact, from the time of the capsule summary being approved to the activation date was really only 1 year. And that has nothing to do with me. It really has to do with the fact that everybody at SWOG and the NCI was committed to getting this open. The other thing that the story I like to tell is that the initial N of 268 patients was planned because there was a real concern from the NCI that we would not be able to accrue quickly. As a result, the initial stats had to be designed around a much smaller group of patients, a smaller N. And as such, the hazard ratio was, to those of us who treat this disease and are in GI oncology, we felt was really quite unattainable. We really wanted a 400 plus patient study and wanted to be able to look at hazard ratios that are really the ones that are relevant and used in biliary tract cancers. So when we did open, we had a target monthly accrual as listed here, just about right under 10 patients a month was our target. And as you can see, the study opened in December of 2018. The first patients went on in February of 2019. And as you can see, we smashed it. The NCTN's cooperative groups really came together and accrued like wildfire. And so by January or so of 2020, we had actually already hit our 200 plus patients, close to 268 patients. So we went back to the NCI and we actually said, I need you to look at these numbers and recognize that there is clearly a need for a frontline biliary cancer study that is open across this country because patients are coming onto this study rapidly. And so they were very kind. They allowed us to amend the study. That's where this drop happened because we closed the study for an amendment to switch around the total N, increase the N to over 400, and then picked right back up in terms of accrual rate. And as you can see, this was a team effort. These are the breakdown of sites, of PIs, and accruals by group. And this, while SWOG, of course, was an active participant, you can see fantastic contributions from the from Alliance, ECOG, Akron, NRG, and from centers that are MD Anderson, but also smaller centers. And investigators were committed to making sure that this study was completed quickly. And what we do know is that there was 2 planned interim analyses. The first one was in February of 2021, and that interim analysis, the DSMC recommended continuing as planned. And then our second and last planned formal interim analysis just occurred in the fall. And again, the interim was recommending that the trial continue as planned. So there was no safety concerns, no concern for hitting futility at endpoints. And so now we are just awaiting the final readout of OS. I think the most exciting part of this study is the fact that this is going to be the largest prospectively collected biospecimen repository in this disease. And this is data from the SWOG Biobank as of October of this year that shows the number of archival slides as well as blood. So we collected blood on 9-week cycles. And you can see that this is a large kind of untouched treasure, in my opinion. And there are a lot of ideas going around about the things we should do, the questions we should ask, and how we can learn from this study, regardless of the OS outcome. So in terms of GAP for all, people ask me, do I think GAP is here to stay? I do. Not necessarily because I think SWOG 1815 is going to be positive, but I think that it's probably a regimen for some patients. I think we just need to be smarter about selecting the right time for using it. I think it probably is going to have a role in neoadjuvant or downstaging. As you can see, there is a study that was led by your own Dr. Maithal here at Emory, and this was a neoadjuvant study looking at what he defined, or what the surgeons defined, as oncologically high-risk resectable intrahepatic cholangiocarcinoma. And the idea here was to look at this in patients to see what the feasibility is of giving this in the neoadjuvant setting. I think in good PS advanced patients, it could be considered, but clearly not all triplets are created equal, as you can see. I mean, FOLFIRINOX did not do what we thought it would do. So I think GAP will have a role, but I also don't think GemCis is going anywhere per se. But I think that the legacy of GAP is going to be incredibly meaningful. And that's not, again, regardless of what happens in the frontline setting. I think we're going to get an updated real world understanding of where we are with BTCs. We're going to have a new median OS for GemCis, let alone the triplet. So the control arm, I do not think the median OS of GemCis is 11.7 months. Most of us don't. And we will get an updated number for that, so that that can be used for future studies, for powering future studies. I think we will learn from the biospecimens regardless of the winner. I think there are patients who can safely tolerate triplet chemotherapy, and I think those patients probably could merit utilization of GAP, and that the GAP should be used and explored in the perioperative or downstage space. But I think most importantly, what we have proven to the NCI and to ourselves and to this country is that we can do a randomized phase 3 trial in biliary tract cancers in the US and answer clinically meaningful questions quickly because of this community of patients, advocates, and researchers. And that's really why I am so proud to be part of the biliary cancer research space, because everybody is committed to getting questions answered so that we can get drugs to our patients. So moving on, I do think that there are other chemotherapies that are getting exciting, and especially in the kind of post-GemCis setting. And Nifty is definitely one of them. I will be honest, I treat pancreas cancer. I'm not crazy about Biliary in pancreas cancer. So I was a little surprised to kind of see this data, but I think this is intriguing and it needs to be better understood. So Nifty was an open label randomized phase 2b study that was presented at ASCO earlier this year and has since been published in Lancet Oncology. This was a study done in Asia only and involved second-line patients after GemCis who were randomized to Biliary nanoliposomal irinotecan with 5-FU leucovorin versus 5-FU leucovorin alone. And the primary endpoint was blinded independent central review of PFS. I will point out that, as we tend to see in more Eastern studies, this was a more even distribution of intrahepatic, extrahepatic, and gallbladder cancers than what we see typically in the US. And a third of patients had previously undergone surgery with curative intent, which speaks to potentially the biology of some of these patients. And so I think that's important to put into context. Regardless, it's some definitely in provocative efficacy data. Median PFS of the combination in 88 patients was 7.1 months in the Biliary 5-FU arm versus 1.4 months in 5-FU alone, with an objective response rate of just around 15%. So again, not to compare, I know you shouldn't, but median PFS, remember, of FOLFOX was about 4 months, 5% response rate. And then median OS was 8.6 months versus 5.5 months, with a nice slight, again, separation of the curves at the 6-month survival, 6-month OS rate. So I think exciting. I do think, again, it was a small, not global study with a kind of slightly different mix in terms of biliary tract cancers and a higher percentage of curative resection than we typically see. But still, I think speaks to a potential use for nanoliposomal irinotecan in the second-line setting. You can see that in the independent review, investigator review assessed, there was a slightly higher response rate, but still waterfall plots shown as such. And overall, the toxicity profile is what we would expect to see with a liposomal irinotecan, including kind of primarily myelosuppression types of issues like neutropenia. And then here in the forest plot, you can see that most patients seem to favor the combination regardless of a number of pre-specified questions related to primary tumor site, et cetera. I will say that you can see, again, these are small numbers, so you need to keep that in context, but a slight kind of favoring of gallbladder over perhaps the cholangiocarcinomas. Subsequent to that, just earlier this year at ESMO, we also had the KNIFE trial. Now, this was looking at Biliary 5-FU versus GemCis. So this was patients in the frontline setting, and they were randomized 1-to-1 and looking specifically only at intrahepatic and extrahepatic cholangiocarcinomas. And this was a Simon two-stage design with PFS rate at 4 months being the primary endpoint. You can see 93 patients were enrolled, and it was about 2/3, 1/3 in terms of the split between intrahepatic and extrahepatic. And again, kind of in terms of well-differentiated and what they called fairly differentiated, which is interesting to me, that it was 50% kind of, again, better, if you will, characteristics in terms of differentiation. Here, the primary endpoint was 51% at 4 months with Biliary 5-FU. Now, keep in mind, this was the pre-specified endpoint, and it was not powered to compare per se to GemCis, but it was looking for specific meeting its primary endpoint. And that was 50, I believe it was set at 50%. So 51% technically met its primary endpoint. My opinion, I don't necessarily think this is as exciting. I think there's something, in my opinion, that requires gemcitabine in the frontline setting for our patients, or maybe gemcitabine and platinum. But this was nanoliposomal irinotecan, in my opinion, acting not as favorably, at least in the frontline compared to the second line. Here, these are the pre-specified endpoints and subgroup analyses, and you can see that perhaps extrahepatic seem to do better. Again, I think these are really small numbers, so it's hard to make a whole lot of sense of this. But we always talk about extrahepatics being a little bit more pancreatic-like, which again may suggest perhaps why a Biliary 5-FU regimen may work slightly better. So let's move into the space of targeted therapy, because I know that's everyone's interest. And as I said, we have a lot of different reasons for one size doesn't fit all. But I think this graphic really shows why, at least molecularly, we cannot be talking about intrahepatic, extrahepatic, and gallbladder cancer as all the same disease. You can see that there are very distinct molecular alterations depending on the tumor type. So we'll start with IDH1. IDH1 is seen in about 20% of intrahepatic cholangiocarcinomas. It does not seem to be prognostic in patients with cholangiocarcinoma. And the mutation results in accumulation of an oncometabolite, which is 2-hydroxybutyrate. This is the phase 1 study that looked at an oral IDH1 inhibitor, ivosidenib. And in this phase 1 study, 73 patients with IDH1 positive cholangiocarcinoma were enrolled. And as you can see, there was some intriguing efficacy in a very highly refractory patient population, with a swimmer's plot with some patients staying on this treatment for some time. So based on that, the Clarity study was designed. The Clarity study was the pivotal phase 3 study that looked at patients in the second and third line setting who had IDH1 positive cholangiocarcinoma. They were randomized, double-blinded and randomized 2-to-1 to receive ivosidenib alone versus placebo. At the time of this study, FOLFOX ABC06 had not come out, so there was no standard of care after GemCis. Because placebo was the other arm, it was really strongly felt that crossover needed to be allowed. And as such, the primary endpoint had to be progression-free survival. Here you can see the treatment duration in terms of swimmer's plots. And I think it's important to point out that 43 placebo-treated patients, which is 70% of patients who were on the placebo arm, were crossed over to open label ivosidenib at the time of progression. And 25 patients, including 6 who crossed over, actually remained on ivosidenib for greater than or equal to a year. So some patients really did seem to benefit. Here's the primary endpoint of PFS by independent review. You can see that there was a 63% reduction in the risk of progression with the use of ivosidenib. Again, the median doesn't tell the whole story. The placebo arm was 1.4 months median PFS versus 2.7 months. But as I mentioned before, steep drop off on the curves, and then this clear separation at the 6-month and 12-month rates of PFS. And disease control rate was 53% versus 28%. Very small amounts of response, but still stable disease, reasonable amount. The overall survival final analysis, the intention to treat analysis, showed a numerical improvement in median OS from 7.5 months to 10.3 months. But a pre-specified analysis was done that was called the rank preserving structural failure time, which I describe as kind of taking out the noise of what happens when patients cross over. If you do that, then the median OS for placebo gets adjusted to 5.1 months. So a near doubling of median OS with a hazard ratio of 0.49 in that situation. But the intention to treat analysis was technically, statistically not significant, hazard ratio of 0.79. That being said, all of this was submitted to the FDA, and Servier announced the FDA approval of ivosidenib in August of this year. Now, I think we are learning about IDH1 resistance. There was an N of 1 paper that was initially published that looked at the potential use of how to use CTDNA to understand resistance. And you can see here in somebody who was on ivosidenib who had a nice response initially, radiographically, they started to develop progression right around day 390, right before day 400, essentially. And you can see in the CTDNA that the R132C IDH1 clone kind of disappears. And right around the time of progression, you see the emergence of an IDH2 R172V clone, suggesting a potential switch mechanism, switch isomer mechanism. That being said, this is an N of 1, and we have actually not seen that on some follow-ups studies and papers. We have seen the utility of CTDNA in association with PFS in patients on Clarity. So here you're looking at patients who cleared mutant IDH1 in the purple versus those who did not. And you can see clearly that PFS was better in those who cleared the mutant IDH1 in their CTDNA. But I think in the space of IDH1, this is an emerging and rapidly changing space. There are other IDH inhibitors on the market and in trial right now. And then, of course, we do have patients with IDH2 mutations that we have to wonder, do we have something that we can develop in that space? The ones that we had have not been developed. Loxo just opened their phase 1 to include potential use of IDH2 patients and potential enrollment of IDH2 patients as well. These are very well tolerated drugs, so they could be potentially combined, but we need to think about what makes sense. What is synergistic in combining? Like, should we just throw it onto GemCis? There's some intriguing preclinical data with PARP. Should we combine it with PARP inhibitors, immunotherapy? And then in a pretty cytostatic drug, is there any utility in looking at this in the neoadjuvant or perioperative space? So I'll move on to FGFR2 fusions. FGFR2 fusions are seen in about 15%, 10 to 15%, really, not 15 to 20, I think, of intrahepatic cholangiocarcinomas. They've been tested in multiple trials, and we do think that they are prognostic. Now, these are FGFR2 genes that are fused to a myriad of partners. And at least from what initial data suggests, patients with FGFR2 fusions seem to overall do better. This is the open label phase 2 study of infigratinib. This was actually the first drug in clinic. This was the first drug that we were trying in patients with FGFR2 fusions, and the final data was reported out earlier this year. In cohort 1, patients with FGFR2 genes fusions and rearrangements were enrolled, and that's what this data is showing. Patients were on infigratinib until progression with dual primary endpoints of objective response rate and duration of response. I just want to point out that the FGFR2 gene fusion or rearrangement, it does not matter what their partner is. As you can see, there's a number of partners. BIC1 is the most common partner seen, but in this study, for instance, all of these additional partners were noted, and 41% of patients had novel partners. Here, the objective response rate in 108 patients was 23.1%. That being said, when you look at 46% of patients who received infigratinib, specifically in the second-line setting, the objective response rate increases to 34%. So suggestion that the earlier introduction of targeted therapy results in better efficacy. The median progression-free survival was 7.3 months in these patients. Again, pretty impressive in the second line, and even in the later lines of therapy was still 7.4 months. This is the waterfall plot that demonstrates that most patients derive some benefit from infigratinib. And as such, on May 28th of this year, infigratinib was FDA approved for patients with FGFR2 gene fusions and rearrangements. That being said, these are accelerated drug approvals, and so they are contingent on confirmatory studies. This is the confirmatory study that is ongoing for infigratinib. This is the PROOF study, which is a frontline study, because the question is, if infigratinib works, could you use it in lieu of GemCis? So this is a frontline study in patients with FGFR2 gene fusions or rearrangements that has to be confirmed by local or central lab. Has to be identified by local or central lab. And in these patients, they have just recently amended the study, recognizing that it takes time to get biomarker testing back, to allow patients the option of 1 cycle of gemcitabine-based chemo while we're waiting on biomarker results. If they have an FGFR2 gene fusion, then they're randomized 2-to-1 to infigratinib versus GemCis. And they have the option to cross over if they're on the GemCis arm at the time of progression. Primary endpoint is PFS confirmed by blinded independent central review. And secondary endpoints, of course, include overall survival. So this study is ongoing, but as you can imagine, is being a little slow to accrue because it is very hard to A, find these patients, and B, until this amendment is really live, it's hard to withhold treatment on patients until we know if they have an FGFR2 gene fusion. This study, the FIGHT 202 study, is actually the first drug that really led to an FDA approval. This is pemigatinib, also an oral FGFR inhibitor. Here you can see that in these patients, the overall response rate was 35.5%, slightly higher, but I will point out that more patients, 61% of patients, were in the second-line setting in this study, again, suggesting earlier introduction of these treatments results in better outcomes. The median PFS in this group was 6.9 months. So everything, we're starting to get a sense here, around median PFS of 7 months. And this was the first drug FDA approved. Pemigatinib was FDA approved in April of 2020 for patients with FGFR2 gene fusions. And again, that was a rapid accelerated approval. And there is a frontline pemigatinib FIGHT 303 study that is ongoing as well. And then the last drug is futibatinib. Futibatinib is also an oral FGFR inhibitor. It is slightly different in that it is a covalently binding inhibitor as opposed to the first two, infigratinib and pemigatinib, that bind in the kinase domain. They're an ATP binding drugs. But futibatinib is also, again, a single-arm phase 2 study, the Phoenix study, with a primary objective response rate endpoint. Here you will see that the objective response rate was 37.3% in the 67 patients that was reported by Dr. Goyal and colleagues at ASCO of last year. And again, median PFS was 7.2 months. So ORRs in the 25 to 35, median progression-free survival around 7 months. That's what we're seeing with FGFR inhibitors. Now, I'm not going to go in depth into FGFR resistance. What I will say is, as we have given more and more FGFR inhibitors in these patients, we are learning that resistance, of course, not surprisingly, is emerging. We're using CTDNA and really some beautifully elegant studies from MGH and Dr. Goyal and colleagues to really understand that the resistance that emerges seems to be polyclonal, and that there may be utility in sequencing FGFR inhibitors based on the types of mutations that are emerging. For instance, gatekeeper mutations that emerge in patients who are on something like infigratinib or pemigatinib that prevents the binding of these drugs in the ATP binding pocket, perhaps could derive benefit from futibatinib, since it is not binding in that same binding pocket. So I think the utilization of CTDNA in this space is going to be very important as we better understand resistance. Now, points to consider in this space, there are a lot of drugs in this space. So first of all, there's all the frontline studies. Infigratinib, futibatinib, and pemigatinib all have frontline studies. There are also a bunch of new drugs. I didn't show you the relay data or some of the other kind of really exciting drugs that are starting to look at FGFR inhibition that also perhaps seems to circumvent some of the resistance mechanisms. So there's a lot going on in this space, and I think we're going to have a lot of potential drugs with the need to figure out how to sequence them. I think we're still understanding the natural history of FGFR fusion patients. And of course, in a drug that actually has response, can we use this in other settings? Can we look at it in the front line, of course? Can we give it with or without chemo? Can we use it in the perioperative space? Again, Dr. Maithal and I are collaborating on a neoadjuvant study, for instance, of infigratinib in patients who have FGFR2 gene fusions and could potentially be going to the OR. I think these types of questions are going to be important to ask. And I think we need to get a better understanding of resistance in order to figure out how we can sequence, because we're going to have a lot of drugs available and we're going to want to be able to sequence them. So moving on to HER2, it's been a big year for the HER2 story. So first data that came out, HER2 we see primarily, and as you remember, in extrahepatic cholangiocarcinomas, as well as gallbladder cancer, 10 to 15% or so of both of those diseases. Zanidatamab's data came out at GI ASCO this year. This is a biphenotypic HER2 monoclonal antibody. And you can see here in 20 patients, small group, but objective response rate in a very refractory patient population of 40%. With a reasonable duration of response. And then when this came out, this was also huge. This was the MyPathway study. We've been waiting for this data to be published. This is pertuzumab and trastuzumab for HER2 positive patients with biliary tract cancer. This was a basket study, and there was a specific biliary tract cohort. And as you can see, again, there were clearly patients that derived benefit. This had a mix, a smattering, if you will, of intrahepatic, extrahepatic, gallbladder, and ampullary cancers. But overall, you will note that the objective response rate was 23%, with a median OS of 10.9 months. So clearly there is utility in targeting HER2 in these patients, and there's actually a lot of drugs looking at HER2 targeting in biliary tract cancers. We have seen this data before. This is the ROAR data, just you can't not mention it. Patients with BRAF V600E mutations, 5 to 7% of patients with cholangiomas typically, really derive benefit from the dual BRAF MEK inhibition of dabrafenib and trametinib. The ROAR study had a biliary tract cohort of patients, and as you can see, the response rate, overall response rate was 47% in this, again, refractory patient population. I can tell you, I put a lot of patients on this study, and this combination works. Really can be quite durable. So in terms of other targets, I think clearly we need to profile, because there are rare but relevant targets outside of FGFR2 and IDH. We need to understand, again, combinations and resistance. And, sometimes the questions are being asked of, do we need an alteration to use targeted therapies? And I think these are all kind of unknowns. And so in the last few minutes, I'm going to, of course, talk on immunotherapy, because no talk is complete without talking about it. We know that mismatch repair deficiency, MSI high, the pembrolizumab approval is obviously relevant, but is only seen in about 1 to 3% of biliary tract cancers. So when we looked at single agent checkpoint inhibition, such as the Keynote 158 data, for instance, which was a biliary tract cancer cohort of 104 patients, no MSI high patients, we were pretty disappointed. 5.8% response rate, regardless of PD-L1 status in this study. Then there was a multi-center study looking at single agent nivolumab here in the US. And yes, by investigator review, there was a 22% response rate. But when you look at central review, it drops down to 11%. So, single agent checkpoint inhibition, pretty underwhelming. So of course we were excited about combinations. So bintrafusp alpha was a combination fusion protein anti-TGF beta with PD-L1. And this is the early data that was seen with a monotherapy phase 2, kind of in the second line setting. And again, across biliary tract cancers, somewhat exciting in terms of overall response rates, with an overall response of 23.3%. And so the Intrepid study was the frontline study looking at GemCis plus bintrafusp alpha. All of us were anxiously awaiting that study, and it was unfortunately stopped. And so in August of this year, all we know so far is that the Independent Data Monitoring Committee stopped Intrepid because it was felt that it was unlikely to achieve its primary objective of overall survival. And so that was incredibly disappointing, and I'm sure for everybody active in the immunotherapy space, a little bit surprising. This was the other area of great interest, of course. Can we add immunotherapy to a chemotherapy backbone. And this was based on, this was a phase 2 study done specifically in Korea that looked at Gemcis plus Durva plus or minus Tremi. This was Dr. O and colleagues, and this is data she presented at ASCO of 2020. And as you can see, when you add Durva, forget about Tremi, even if you don't need Tremi, because when you add Gemcis plus Durva, you see an impressive median PFS of 11 months and a median OS of 18.1 months. But this was an all Korean patient population. So the question was, what does this look like when you do a global study? And so this study was the basis for the TOPAZ-1 study. TOPAZ-1 was a global randomized phase 3 study of 672 patients who were to receive Gemcis plus Durva versus Gemcis plus placebo. Importantly, because of how a lot of the rest of the world gives Gemcis, after 8 cycles of Gemcis, patients entered maintenance. So they could continue maintenance Durva versus maintenance placebo with a primary endpoint of overall survival. It's stratified by disease status, meaning unresectable, recurrent, et cetera, and primary tumor location. I'm a little disappointed to see it is not stratified by region, because I think this is going to be a heavily accrued in an Eastern patient population. And we kind of know that the immunophenotyping of that population suggests a slightly more immunogenic type of population. But all we do know so far is this press release. This is the press release that came out a couple weeks ago and has created a huge sense of excitement in the biliary cancer world. So what we know is that TOPAZ-1 was stopped during its interim analysis because it met its primary endpoint. It improved overall survival. The data has not been released yet. Word on the street is GI ASCO, so we're all very excited for that. But I think it's very possible that we have a new frontline regimen. There are a number of other studies going on looking at immunotherapy with Gemcis, for instance. That includes Keynote 699, which is the addition of pembrolizumab. But there are studies that were already done. So for instance, the BILT-01 study, which is run by Dr. Sahai and colleagues specifically in the States, looked at Gemcis plus Nivo, for instance, and it was really not that exciting. And so you have to wonder what is going on in this space, frankly. So we know that TOPAZ-1 is positive. We have no idea. Keynote 699 has finished accruing, but we don't know what its readout is. And then we know Intrepid was negative. And so I think this is going to be in the next year or so, I think we're going to have a lot of updates. There's some interest, of course, looking at immunotherapy with TKI combinations. Everyone loves the lenvatinib pembrolizumab combination because of what it's doing in other tumor types. In the LEAP-005 study, there was a 31-patient biliary tract cohort with an overall response rate of 10%. Can't say I'm that excited about that, but what we do know is that that has been expanded to 100 patients. And so I think that will help us get a better sense of what lenva pembro is doing in biliary tract cancers. There are other studies that have come out, for instance, from China that are looking at lenvatinib plus toripalimab, also a checkpoint inhibitor with, for instance, chemo like GemOx. And again, really impressive overall responses of 80%. But these are small studies, and again, in an all Asian population. So I think, again, the global studies will really help us tease this out better. So in terms of immunotherapy, I think my feeling on this is clearly it was down, but it's not out. Clearly, we need combinations to turn microsatellite stable tumors hot. I think Gemcis plus the PD-L1 or PD-1 studies are clearly very important. There's a lot of pharma-sponsored studies. There's a lot of really great, smart people working in this space, including your own Dr. Lisinski. And so I really think we're going to crack this wide open very, very soon. Dr. Kelly, this is outdated data now. She presented this at ASCO of 2018, but she had a phase 2 study of pembro plus GM-CSF, priming the microenvironment with GM-CSF. And she had seen some kind of intriguing early phase data and was adding on patients to do paired biopsies and to really understand what's happening in these patients. And there's a lot of really interesting work happening using and leveraging our science to really understand the immune microenvironment better. I think that is a really exciting time for it's an exciting time for immunotherapy, but I think in general, it's an exciting time for biliary tract cancers. So where to next? Clearly, there's a role for profiling all cholangiocarcinoma patients. I mean, we spend so much of our time just trying to educate people on the importance educate physicians, patients, et cetera, on the importance of biomarker testing. Every single patient at the time of diagnosis needs to get this done. And then, I think we're learning basket trials can really help us answer questions. These biliary tract cohorts within ROAR, within my pathway, this is how we're getting questions answered for rare alterations. And I think that's the way to continue. It's still a little tricky. Availability of tissue, like I said, remains an issue. I think CTDNA is really going to be the new frontier. We just need to get it to a place where we, for lack of a better way of saying it, trust it. The sensitivity, for instance, for FGFR2 fusions is not quite there yet, but this is evolving so quickly that I think very soon CTDNA will be a way of doing this fast. I think it's important to point out that the ABC06 results are out. And so we do have a new second-line standard of care, technically with FOLFOX, and maybe with NIFTY, we may have something else. And so all of these targeted therapies have been looked at as single-arm studies, and we need to put all of this in context. We need randomized studies now. Are all cholangiocarcinomas and biliary tract cancers created equal? No, but how should we be stratifying? So for immunotherapy studies, should we be stratifying specifically by region? Should we be stratifying by molecular alterations? Because maybe FGFR2 fusion patients are not responding as well to X, Y, and Z versus others. As I mentioned, basket trials are going to be really important. And I really think understanding resistance is key. Repeat biopsy, CTDNA, utilizing technology so that we can understand this better is going to be key to be able to develop the second generation, if you will, of targeted therapies. So in conclusion, I really fully believe one size does not fit all. It is a new era in the treatment of cholangiocarcinoma and gallbladder cancer, even in chemotherapy. But yes, I'm biased. Sequencing can and should be done on all patients. We have 3 FDA drugs approved. This is unbelievable. Before COVID, we had 0. It's amazing to put that in context. And I think we have more to come. Futibatinib has applied. I think that will be FDA approved as well. Actionable targets exist. We need to go after them with smart clinical trials, and we remain hopeful for immunotherapy. And I have to ask, maybe we have a winner, and we're going to have a new frontline king and have to build off of that. With that, I thank you very much for your time, and I'm happy to answer any questions.
Thanks, Dr. Shroff. If you have any questions, please use the Q&A feature located at the bottom of your screen. While we wait on questions, and I see a few in the chat, I wanted to let you know that this Grand Rounds lecture is the last of 2021, and we will return with more Grand Rounds lectures on January 14th of 2022. So thank you all for helping to make this year of a virtual Grand Rounds successful. And as always, to view all upcoming Winship Grand Rounds lectures, please visit the Grand Rounds page on the Winship Cancer Center website or the Winship calendar. So thank you, Dr. Shroff. I'll start with a few questions in the chat as the Q&A continues to populate. The first one is, let's see, from Dr. Shah. It says, thank you, great presentation. What is the incidence for grade 3-4 sensory neuropathy with GAP? In your opinion, do you think every other week of GAP is better than 1 in 8?
Okay, these are loaded questions. So don't tell SWOG I said this, but yes, I like every other week. Outside of protocol, I'll be frank, we tried to actually pitch an every other week regimen, both in the initial phase 2 as well as in the study. I mean, the honest truth is the concern is the apples to oranges comparison, right? GemCis, at least ABC02 style is day 1, day 8 of a 21-day cycle. Off protocol, I do give it every 14 days. It's much better tolerated. It's much less myelosuppression, which is really the primary toxicity that we see. Even with the day 1 and day 8, that myelosuppression is usually mitigated by using, growth factor and things like that. But, because patients do well on this regimen and they stay on it for a long time, it really does become cumulative. And so an every 14-day schedule, I think, is just from a quality of life perspective better. In terms of sensory neuropathy, surprisingly, we actually in the phase 2 did not see a significant incidence. The grade 3-4 in terms of sensory neuropathy was actually less than 5%. And I was surprised as well because of Abraxane. The honest truth is that the ongoing study so far, at least, because we obviously look at the toxicity data, that has not been a signal yet. So obviously I need to see the final readout, but hopefully sensory neuropathy will not be the primary concern.
Great. Another question from Dr. Ned Walder. Nice talk and great to see progress in this difficult cancer. The case report from Rosenberg using ex vivo expanded adoptive T cells for biliary cancer is provocative, as are the data you presented on IO drugs. What data are there for expansion of antigen-specific T cells among subjects treated with IO drugs?
It's a great question. I mean, Greg should probably answer this more than me. So far, there is not, I mean, you know, the Dr. Rosenberg study, I love to say, I mean, I very much respect his work, but I love to always say, what was the denominator for the N of 1? But the other thing I will say is, and this is common knowledge, we all know the N of 1 patient, and she was MSI high. So I think you need to put that into context. That was not known at the time of the Science publication, but in retrospect, we have looked, and you know, the Pembro that she has been getting, I think, has been obviously been playing a big role in that. That's not to say that that was not, you know, that technology is not the way to go. I think there's a lot of excitement. I think the problem has been, we have a tendency, and this is unfortunately how drug development works, right? Well, this is what's working in melanoma. So, you know, we started with the checkpoint inhibitors because single agent checkpoint inhibitors were working in all kinds of things. Now we're starting to recognize that combination therapies are where we need to go. And identifying potential, for instance, you know, antigens for, you know, expansion and expression and things in biliary tract cancers, I think has been complex because molecularly they're very complex, and there's not necessarily standout things to go after in extrahepatic intrahepatic cholangio. Yes, there are some targets, but it's not as obvious as a slam dunk as it is, for instance, when you're looking in the CAR T space in hematologic malignancies, for instance. That being said, I think that is absolutely where a lot of people, again, Dr. Lazinski included, are working and focusing. I think with the onset of, or once we see the data from Topaz, and once we understand what these GemCis plus IO studies are doing, I think people, I mean, I hate to say it like this, but there might be more excitement and willingness in terms of people to put time and money and pharma to kind of dig their heels into really expanding the IO armamentarium in biliary tract cancers. But I think it's been a lot of hesitance up until now, frankly.
Yeah, I think we have time for 2 more questions. There's 2 more in the Q&A, and we can talk more about the immunotherapy another time for sure. So a question from Dr. Kubi, one of our GI surgeons. Great talk, thank you. What are your thoughts of immunotherapy, targeted therapy, supplementing major surgery down the line?
Oh, I mean, I don't think, you know, just like I said, I don't think GemCis is going anywhere. In the, you know, 30% of patients where surgery is an option in cholangio, for instance, I don't think surgery is going anywhere. I think that we are getting smarter about multimodality approaches in you know, locally advanced patients. And I think, frankly, the surgeons are leading the charge there. I think they're doing a really great job of being open to considering taking some of our novel drugs and looking at them in the perioperative space. You know, when you look at even HCC, where immunotherapy has been so effective for so long, I mean, not so long, but at least longer than biliary, they're just now starting to look at, you know, perioperative. We've got a SWOG study that's about to open looking at Nivo-Ipi, for instance, in the neoadjuvant space for HCC. And, you know, there's the surgeons who are advising us on timing of this. You know, when do you need to stop these drugs? What about patients who are, you know, for HCC, especially transplant candidates, et cetera. And so I think there's a lot of not complications, but complexities that we need to think through in the perioperative space. And I think with targeted therapies, we have to be smart of, you know, just because something works in the metastatic setting, what is the efficacy? Does it make sense to bring it in a potentially curable patient? You know, and I think, for instance, the reason we want to look at FGFR inhibitors in the pre-op space is because we at least see a response. And so we're not worried in these patients that could potentially be going to the OR that we could be potentially causing trouble or, you know, delaying their care or et cetera. So I think it will be complementary. I don't think it will be, you know, competitive.
Great, thank you. And perhaps the last question, just to keep everyone on time, including you, Dr. Shroff. This comes from Dr. Shin, one of our head and neck medical oncologists. Great talk. I might miss it, but any data available for radiosensitizing, i.e. SBRT, among those targeted agents in cholangiocarcinoma?
That's a great question. Not yet. I'll be frank, radiation alone has had like a moment in cholangio. I didn't show you any of that data, but there's a lot of intriguing data that came out of Anderson and MGH looking at proton therapy and things like that. There have not yet been studies to test the safety and or potential radiosensitizing ability of some of our targeted therapies, but those are conversations that are happening right now with the companies, because again, I think everyone's trying to figure out what other spaces beyond refractory advanced disease can they work in. And so I think those in the next few years, I think we'll start to see those studies.
Wonderful. Well, thank you again, Dr. Shroff, for an outstanding talk and really wonderful example of all the collaborative, multi-site, multidisciplinary research that's been going on in a really tough disease. And I think the future is bright, and you certainly illuminated that for us. And again, we're honored that you were able to give grand rounds today, and wishing you the best. And thank you everyone for tuning in.
Thank you. I appreciate everyone's attention. Have a good day.